electrolytes and fluid and electrolytes.
System. If you were here yesterday, please sign the one that says electrolytes, and make sure you sign the one that says ethylene at the top. Okay, I have my PowerPoint today, but one of them, the one we were doing yesterday, was giving me trouble. This is like going to be the death by PowerPoint. So some of it's cut off. Hopefully it's not cut off on your. There's like a dark cloud of PowerPoint. I'm not even going to worry with it. But I wanted to start out. We left off at magnesium. And when you're talking about magnesium, I want you to think about twitching, okay? Like neuromuscular excitability, okay? So it's going to excite the neuromuscular system. You also can see signs of Trousseau's and Hovig signs with magnesium being off, because you also can see that it works with calcium a lot. So, because calcium, you see those, you can also see them with magnesium. So, our normal level is, well, when we're going by 1.3 to 2.1, and it's mostly in the intracellular space. Sorry, let me put this a little bit way better. Okay. Now I'm hands-free. So basically magnesium is used to activate enzymes, but most importantly is that electrical activity, okay? And that's in the heart especially. It does help with metabolism of carbs and proteins, but the big thing that really you see in the hospital setting that affects the patient right away is that electrical activity in the heart, which affects the muscle in the heart. It is regulated by through the intestine, absorption in the intestine, and secretion or retention in the kidney. So some ways that it affects other electrolytes: magnesium and calcium. If one is low, the other's low. So they're like buddies. They hang out together. Did I say calcium? Yeah. Also potassium. One's low, the other's low. But phosphorus and magnesium have an inverse relationship. So if magnesium's low, phosphorus is going to go high. assessment with magnesium is when it's hypomagnesium magnesemia, you are going to, it's going to be the level we're going by is less than 1.3. And do we have a Amber Alert? Okay. So, like I said, you have cardiac changes, you can have hyperreflexia. It's just really going to be, you're going to be seeing things that go along with that neuroexcitability, the neuromuscular excitability. You also, with this, have a, just like in calcium, you can have a risk for seizures. So these patients are going to need to be on seizure precautions. And if you don't see signs of low magnesium, you are going to be seeing signs of low calcium because they go together. So, you know, they just kind of mirror each other in that aspect. So it may not be actually the magnesium that's causing the problem, but you're going to be seeing those signs and symptoms of calcium, yes.
Okay, just to clarify, so magnesium up, calcium, and potassium go up?
Go low.
And if magnesium is up, phosphorus goes down.
Right. So calcium and potassium have the same response as magnesium. Inverse response or relationship between magnesium and phosphorus. Okay, so they're the opposite. The way we're going to treat this is you're going to treat with IV fluids, oral supplements of magnesium. Also, you're going to need to restore the calcium level because if you don't restore one, the other one's not going to move either, okay? So you have to restore them together. Sorry, this is cut off again. You can have decreased intake. Of course, any way that you can get the magnesium inside your body. Chronic alcoholism is because it affects the GI absorption of magnesium, and any of the different problems, long-term problems like ulcerative colitis, irritable bowel syndrome, those Crohn's, those types of illnesses can cause a low magnesium as well. They're losing it through the stool as well, and the absorption problems they have. It is it also is controlled somewhat by the parathyroid. So if you have hypoparathyroidism, you're not going to have as much magnesium, just like the calcium levels. And of course, NG tube suctioning, anything that's taking that fluid out of the GI system. Kidney disease can affect it because of whether or not it retains it or secretes it. Okay, so in this, the kidney disease, it would be secreting too much of the magnesium. Critical value is less than 0.5, and it's a really common electrolyte disturbance you're going to see in really critically ill patients. Okay, these are patients in the ICU that are bedridden for a while. They aren't moving around. They have a prolonged MPO, so they're not eating and drinking. Also, they found with magnesium, patients that are in the ICU or in the hospital after having a cardiac MI, having a heart attack, if they don't, the ones that they make sure their magnesium levels stay stable and within normal limits do much better than those where it fluctuates more. So it does have a really strong effect on how well the heart heals after an MI. And if it is too low, it can cause cardiac arrest, and that's usually through a rhythm that starts out at, you'll hear it called torsades, and you'll learn about that in when you do cardiac. Have y'all learned about that? No. You're doing cardiac this semester, right? You'll learn about torsades. And it's a lethal rhythm that can go into cardiac arrest. So very important. Magnesium as well is used for preeclampsia. I'm sure you guys have known someone that was with a child, if you haven't been yourself, and sometimes with preterm labor, they'll use the magnesium to treat that because it helps to stop the contractions. Hypermagnesemia, greater than 2.1, you're going to see nausea and vomiting. You're going to have hypotension, bradycardia. Also, you have to be careful because of the muscle weakness, remembering that the respiratory system is driven by a muscle as well. So if that gets too high, it could affect that, and it could be respiratory depression or respiratory arrest. With this one, everything's slowing down. You're going to have the muscle weakness, the hypertension. They're going to be lethargic. They're going to be real groggy, not up, moving around. Heart's going to slow down. Critical value is greater than 3. You want to monitor their vital signs because of the risk of problems with the bradycardia, with heart rhythm problems. You're going to want to monitor that. You're also going to want to restrict intake of magnesium and give them a diuretic if it is deemed appropriate. That's how they treat them. Respiratory depression is the most severe complication of toxicity, so that's pretty bad. You don't want anybody stopping breathing. Okay, so causes of this: renal failure and increased intake. Okay, so in this case, the kidneys aren't flushing it out. They're not able. They're retaining and reabsorbing it. Excessive intake of magnesium-containing acids, and that's something people don't think about a lot, especially the older folks who may have some kidney problems or kidney complications, and then they take antacids on top of it. It can cause a real problem for them with an increased magnesium. Any question about this? So we're going to talk about phosphorus. 3 to 4.5 is our number, our normal. It is basically provides energy to muscles, okay? And you have to, as part of that ADP, you're going to have that to make energy. It also helps in the formation of red blood cells, which carries oxygen, so it helps in oxygenation. It helps form cell membranes, and the majority of it is in the majority, 80%, is in the bones and teeth, along with calcium, and 20% is in the intracellular fluid. So the intracellular is where you're going to see the majority of it. There will be some in the extracellular fluid, but it's mostly going to be in the cell. Critical value is less than 1. Again, here you have that reciprocal relationship with calcium. It also is an anion buffer to the acid-base balance, to help regulate acid-base balance, and you'll learn more about that with Professor Bowen tomorrow. It is regulated by the parathyroid hormone, vitamin D, and calcitonin, and those 3 things decide and tell the body whether to absorb phosphorus or to secrete it through the urine. You have less than 3 is considered hypophosphatemia. You're going to have problems. You're going to have neurological problems. You're going to have constipation. You're going to see muscle weakness. So in this one, in phosphorus, things are slowing down if it's low. Hypoactive bowel sounds. Because think about it, if the gut is not moving, it's not working, it's not going to be absorbing phosphate as well. Interventions, you're going to restrict intake. And again, diuresis, you're going to give diuretics. And again, with phosphate, you're going to monitor vital signs closely, partially because of the oxygenation, but also, more importantly, because of the effects to calcium and potassium. Okay? Because when this goes low, those go high, right? Critical values greater than 1 is less than 1. Did I do it? Oh, that was the other one. Okay, that was magnesium. Okay, phosphorus and calcium have the reciprocal relationship. You're going to need them on seizure precautions because that's one of the neurological issues. Yes?
I'm sorry, what are you restricting the intake of?
I'm sorry?
What are you restricting the intake, just in general, or?
Phosphorus is actually a byproduct of protein. So it's not, there are some that have high phosphate levels. It causes a real problem in kidney failure. And you would have, you'll learn more about that in kidneys. I don't want to overwhelm with that. But, so you'd be restricting some proteins that the byproduct is really high in phosphate. Oh, that's a good question. I'm sorry. Maybe that's not right. Just cross that one out. Sorry, now I see where you're coming from. We're in hypo. You would restrict it in hyper. Sorry about that. Oh, I got it. Potassium and calcium. High boost containing potassium, calcium because of the inverse relationship. Because if they go high, this is going to go low. Oh, that's incorrect. That's incorrect too. So let's just cross it out and let's move on. Okay? It's probably magnesium, but let's just move on. Yes, cross that out. Restrict intake. Professor Witt does not know what you're going to restrict. Yes.
If it says phosphorus and calcium have a reciprocal relationship, you increase the phosphorus and it decreases the calcium?
Right.
Is that inverse?
It's inverse. I said it wrong over there.
Okay.
Just now. I totally confused everybody even more.
Well, on the left,
Yes.
it should be inverse. It should be inverse.
Phosphorus and calcium
Have
reciprocal?
yeah, they have an inverse relationship.
In the previous slide.
It did say inverse,
It just
didn't
sounds
it?
weird.
No, it said reciprocal.
Yeah, it should be.
And then on your alert, it says reciprocal also on the second slide.
Hold on.
I just,
Now I am totally confused. I want to make sure I tell you the correct thing. But previously I had inverse, correct? Alright, I've got it written down here. It should be, yes, phosphorus. I'm so sorry. Phosphorus. I was thinking about magnesium. I apologize. So that is correct. Calcium and phosphorus are reciprocal. So if calcium goes down, phosphorus goes down. So that's why you would restrict calcium. Or you would, no, you would not restrict calcium. I'm sorry, you would not. Yes.
Did you say that the potassium and the phosphorus have an inverse relationship?
I did say that, but that calcium and phosphorus do have an inverse relationship.
so one goes down and one goes up.
That's reciprocal. Okay, that's wrong. That is wrong. It's an inverse relationship. Okay, calcium and phosphorus. Yes, I am so sorry. And calcium and magnesium also have an inverse relationship.
Okay, can you please say again?
Calcium and phosphorus have an inverse. That's incorrect.
Wait. No, you said wrong.
Calcium and magnesium.
Like the incorrect.
Calcium and magnesium.
They have an inverse relationship. Magnesium. Okay, everybody settle down. The The instructor's confused. We're going to get it right. This is incorrect. They have an inverse relationship, okay? Yes.
I'll wait till after you figure this out, but it's about phosphorus.
Go ahead.
It's just where you said there's calcium component and what's the other two that play around?
Parathyroid hormone and, I'm sorry, vitamin D. Phosphorus and calcium work together. They're in the bone. And what those three are going to do is tell the body how much to release, if it needs to release it from the bone, if it needs to excrete it in the urine, if it needs to absorb it, what needs to happen. So we have sodium and potassium are inverse. One goes up, one goes down. Calcium and phosphorus are inverse. Magnesium and calcium are the same or similar. They have a similar or reciprocal response. Calcium and phosphorus? Inverse. Magnesium and potassium are reciprocal, so they're the same. One goes up, the other one does. And magnesium and phosphorus are inverse. Now, since we're all totally confused, just go by that. Don't go by what's on the slide, okay? Because this is incorrect. So, and I have it again there that phosphorus and calcium are reciprocal. I apologize for that. So, we already did hypo. Well, your treatments. The causes of this, chronic diarrhea, the big one, you're going to see it in calls from the treatment of diabetic ketoacidosis, malabsorption syndromes, because a lot of it is absorbed through the gut. And one I don't have up there, is problems with the parathyroid hormone.
For the causes.
Mm-hmm. Also, there can be electrolyte disturbances or fluid balance disturbances that cause it to shift more into the cell. Patients that are on TPN, which is special IV fluid with a lot of electrolytes and a lot of nutritional stuff that they need because they can't take things in PO, will be on, if they don't put enough phosphate in the bag, the IV fluids, then they can get hypophosphatemia as well. Hyper, greater than 4.5. Big problem with that, you're going to see those, and this says classification, it's supposed to be calcification. Sorry, it didn't alert me to that problem. That's like your kidney stones, crystals, calcium crystals in the corneas, crystals in the heart. It's going to cause your reflexes to be very hyper, and that can cause tetany. Do y'all know what tetany is? It's when the muscles get so tight that they like lock up. Yes. You know, I don't think there is like a critical value that I could find. Okay. I explained to somebody else earlier, it's kind of like the stepchild. We worry about it because of, we worry about the things that it affects. So if calcium, it affects calcium. You're going to see the effects of the calcium more than the phosphate, but if you don't fix the phosphate, the other levels won't be fixed as well. So that's why you will not be talking about phosphate much at all unless you are in with renal failure patients. Those are the ones where you're restricting different things.
Sorry.
No, you're okay.
So if you're having high phosphate, why are you getting calcification? Because high phosphate is going to drop your calcium, right? I'm sorry.
No, you're right. You're right. I'm going to have to look at it again and make sure. I really think my slides are probably correct, and what I told you earlier is wrong on another paper somebody gave me. So I think my slides are correct, but I will check it at break, and I will let you know for sure when you come back, okay? Yes.
Say reciprocal means inverse.
No.
No.
Because like 3 over 1, you have no reciprocal that means 1 over 3.
That's math.
Yeah.
That's
This looks like
in real life.
Like I said, okay, so. Okay.
Okay, I shouldn't have slides today. I should have just left my slides at home. I usually use inverse. Yeah, you know, I'm almost certain my slides are correct. I'm not gonna, well, it's break time. No, it's not. No such luck, huh? Let's move on past that, and I will find out for sure, and I'll let you know. Obviously, if I can't get it straight, you won't be tested on it. So we will do it in a minute. No, I'm going to get it straight after break. I'll be able to tell you for sure because I am totally confused now. Even if I wanted to think straight, even if I thought I knew what that is, I could not convince you of that. Okay, fluoride has a lot to do with the respiratory system. It has a lot to do with when you do ADG. You're going to be hearing a lot about that. It is regulated with the kidneys, and you will almost always find sodium where you find sodium, you'll find chloride tagged along. You think about sodium chloride, that's normal saving. You're always going to really find those two together. Your normal values are 98 to 106, and it also critical are less than 80 and greater than 115. It helps to maintain the osmotic pressure. We're going to talk about that in a few minutes. And like I said, it's acid base, but it also does aids in digestion because it helps to form that hydrochloric acid that is in the stomach that helps digest food. It is the most abundant anion in the extracellular fluid, and that's probably why you find it with sodium, because sodium is the opposite of that. It's the most abundant cation. Okay. Because of their close relationship, it likes to mirror the side effects that you see or the signs and symptoms that you see when you have a low sodium. Again, prolonged vomiting, anything that is pulling or getting fluid out of your body, you're expelling it some way, vomiting, diarrhea, it's being sucked out by NG tube. Also, anything that causes someone to sweat a lot of salt out of their body, they're going to lose chloride. So especially with our cystic fibrosis patients, their sweat is very salty. And so you're going to be losing chloride with that. You're going to maintain it by diet, IV replacement, correct the cause. If they're having diarrhea, you're going to try to stop that. If they're having vomiting, you're going to try to stop that. So whatever the problem is, correct it, give medication to reduce that, whatever it takes. If it's high, it's going to be over 1.6. This is where the big respiratory stuff comes in. It can get so high it causes an acidosis, respiratory acidosis, metabolic acidosis, and that because it's caused by respiratory. You're going to get the respiratory system is going to be trying to blow off that acid, and so it's going to, you're going to see small respirations. Does anybody, do you know what that is? Yeah, it's like belly breathing. It's rapid, shallow breathing. And when you see that patient is super duper sick, and they're probably going to need a ventilator pretty quickly, or they may not survive. It goes along with it. It causes muscle weakness. You think about when you have a high sodium level, what happens to your thirst? It goes up, so same with chloride. So they're going to kind of mirror each other. You want to watch the vital signs. You want to give IV replacement, diuretics. Reorient the patient, because remember, when our sodium levels go up, our chloride levels go up, we can have confusion. Any of those neuro problems can go along with this, because remember, neuro, we're going to think, sodium, we're going to think neuro, so that's going to be the same with the chloride. When you have an increase in the sodium, you could have a decrease in bicarb levels. Okay, so your body's going to get more acidic. That's how you get the metabolic acidosis. So one of the treatments could be to actually give bicarb. Okay, so what are we going to do for these patients with electrolyte disturbances? How are we going to assess them? Big important things, we're going to want to look at their fluid status. So what we're going to be looking at is, what are they taking in? What are they getting rid of? What is their daily weights? Weighing someone is a great way to find out their fluid status. They call it, what is the patient's dry weight? And that's the weight before they put on a lot of extra fluid. So you want to get them back to their dry weight when they don't have all that extra fluid on, if they're retaining fluid. Want to look at their vital signs and also just the physical exam. What kind of things would you be focusing on a physical exam if you were worried about fluid electrolyte imbalance? Skin turgor, mucous membrane, edema.
Did you say clubbing?
A EKG, you want to monitor their heart, absolutely. So blood pressure, all those types of things, which go along with vital signs too. What else? Their skin. How does their skin look? When you have an excess of fluid, it can really affect and cause skin breakdown quicker. Likewise, dehydration in older patients can make them more at risk for skin breakdown as well. Anybody else? Anything else? You want to monitor these patients super close, because it affects so much of the body. That's what makes the body work. And if you are out of balance hemodynamically, you're not going to have homeostasis, okay? So, some of the nursing diagnoses you can use would be, it could be an excess of fluid volume related to excess fluid intake or sodium intake. You have a deficient fluid volume related to active fluid loss or failure of regulatory mechanisms. So if those automatic systems built in the body don't kick in and work, maybe they're taking in too much fluid or food, or the wrong food for what's wrong with them, and that's going to affect the electric. So it could be less than body requirements. It could be more than body requirements. And then also diarrhea. We could go on. It could, vomiting. There's just so many we could just continue to list. But these are just a few. Your nursing care plan. What are you going to want to make sure? You're going to make sure they maintain hemodynamically stable level of what keeps them hemodynamically stable. So a good volume of fluid in their body, not too low, not too high. We want to make sure, we want to check those labs. We want their labs to return to normal. Education, you want to make, one of the goals could be to make sure that they can repeat back to you what are the dietary restrictions or lifestyle changes they need to make in order, and what you need to look for that are signs and symptoms of this problem. So what to do and what not to do. And one thing I was going to say with the assessment, lung sounds. Lung sounds are huge, especially with fluid volume excess. And people, it's really, they can go from fluid volume deficit, someone start treating them and giving them fluid, and they can jump to fluid volume excess really quickly, especially if their regulatory systems aren't working correctly, or they have some sort of organ damage or compromise, okay? So here are some of the ones we already said. You're going to monitor their skin turgor. You want to look at their urine samples. Some floors you can test that on the floor. Some places you have to send it to the lab, but you're going to want to monitor that to see how concentrated the urine is. If they're peeing off a lot, it's going to be more concentrated or less. It's going to be less. If they are not urinating much at all, the urine output drops. It's going to be very concentrated. So you also have to get them fluids in some way. So that could be through oral rehydration. It could be like Gatorade or those types of special. What's the one they give kids? Pedialyte. It could be that sort of concentration, or it could be through oral or parenteral food. So you could be doing the TPN IV if they can't eat, but they have to have the fluid and electrolytes. Check for those those central nervous system, those neuro changes, which are so important. So you're going to be doing neuro checks and keeping them on seizure precautions and that type of thing. Okay. And your evaluation, you're just going to check to see were those goals met. Okay, and you would either write, yes, they obtained this, no further action needed, or no, they did not meet it, and I'm going to revise the goal. We will continue the current care plan until this date. And so it would just change when you want it. You'd either change, maybe you do need to change your care plan, maybe you do need to change what you're doing for the patient. Maybe it just hasn't been long enough, so you can keep with the same care plan, but you just change the date of your goal. Okay. So we have a 5 to 10 minutes before break. 5 minutes before break. I we're not going to break into groups, but I do have a paper for you. I want you guys to pass these around. Yes?
Do you need, in order to obtain urine sample?
Yes. Okay, you want to pass them around. This is a simple matching exercise. And we will go over after break. I'll give you a few minutes, and then we'll go over it, okay? And if you don't know the answers, you will after break, okay? So don't get too hung up on it. We're not going to spend much time on it. Use the 5 minutes now, and then you'll be going to break. If you finish it, you can go to break early, and we'll come back at 1:30. No, you just do it, I mean, you and your person sitting by you want to work together on that's fine, but we're not doing this. Yes. Is there any left? Y'all can pass them on back. The slides are correct. It's just that who said that reciprocal was?
No.
Yes, that's correct. Reciprocal means opposite. Inverse. Got it. So I don't need to change up words. So that is, and I apologize for changing up words.
So reciprocal is inverse.
It is.
Okay. So you would say there were two that go together that are more opposite direction?
Yes. That are the same. Magnesium and calcium and magnesium magnesium and calcium. Sodium and potassium are calcium and phosphorus.
Magnesium and calcium are the same. Potassium and magnesium are the same, are similar. Sodium and potassium are the inverse.
Is Jeremy Lynn your favorite?
Sodium and potassium. Calcium and phosphorus are inverse. Magnesium and phosphorus are inverse. Oh, you were right.
I am. Well, phosphorus has such a like calcium, it's not astronomical as calcium's
And then she
I was sitting upstairs and the director of the program. We were inside. Like, I was cold. So what do you want me to do?
I think you will make
You taking a picture or selfie?
I don't know. But I'll probably change that. It's so hard because they really work together. So like phosphorus does I am for sure. I can smell it. That and also not putting enough having it 5% because it's not one of the main electrolytes that we think about because it doesn't affect the body right away.
I don't want an
If you're given
Yeah, I can make this somewhere. They just gave me one half. No, I think there's a couple. We're supposed to have. Yeah, like a whole line. Oh, wait, you don't have that. No. I'm gonna go back. Yeah. That's just not that bad.
One day.
And then what you're seeing is just like so why do you want to be a nurse? And I was like, yeah, it's like, because I want to see people. You said all of them. I said all my things. I'm saying. That's all.
Okay, I have a quick announcement on yesterday's on yesterday's work that we went over with sodium, with hypernatremia, where it says causes, it should be ECF to ICF, not ICF to ECF. The hyponatremia is ICF to ECF.
Once more.
Where you have hypernatremia, where it talks about hypernatremia causes, it's going to say ECF to ICF.
You write it.
ICF.
Okay, it's supposed to be ECF to ICF.
Okay. For hyper.
For hyper. Hypo is correct. It is ICF to ECF. That was the one that we were talking about yesterday. So I want to make sure you got that correction.
One more.
And I will send out a message, an announcement clarifying that as well. So if you don't get it, I will make sure you Okay, homeostasis. We've gone over this a little bit. I will be trying to post the homeostasis, like little 1 hour thing online. It's not even an hour, but it goes through homeostasis. I think there might be like 4 questions on the test off of those slides, if that. Yes. I don't know. It's up to team lead. I did request that today. So hopefully, yes, we will be. She asked if we're going to be posting the test blueprint, and I am not sure. So I did request that it be posted, and we'll see if that occurs. Okay, so homeostasis. We did talk about this a little bit yesterday. The big thing is to know that that is when the body is equal. It's stable. It takes the whole, every system in the body practically, as you can see how electrolytes are affected. It takes a lot of the body function, a lot of automatic processes and responses in order for homeostasis to occur. If we don't have homeostasis, what do you think we have? Imbalance. And we have illness. That's when illnesses occur. We can cause that imbalance